So welcome everyone to this new episode of Prostate Cancer Prostate Diseases podcast. I'm here with Dr. Diamand and Dr. Mjaess, who will talk a little bit about their recently published paper, which is on, I think, a very hot topic because it's on PI-RADS 3 lesions. So I will start asking you both to introduce yourself, actually, and to tell us a little bit more on how this idea came to you and why did you decide to develop such an interesting research. So please.
So thanks a lot, Ricardo. Thanks for this kind invitation. So I am Romain Diamand, an associate professor of urology at Jules Bordet Institute, a national comprehensive cancer center in Belgium. And I am today with my young colleague, George, so I think he would like to introduce himself.
George Mjaess, I'm a urology resident, fourth year at Université Libre de Bruxelles. I'm one of the residents of Dr. Diamand.
Okay, very good, very nice. So can you tell us, George, you're the first author of the paper, so please tell us a little bit on the design of the study. What were the principal aims of the study and the main outcomes that you evaluated in your cohort?
So the idea came that normally in clinical practice, we do not know if the PI-RADS 3 lesions on an MRI, if we should biopsy or not these lesions, especially that only 20% of these PI-RADS 3 lesions will have an I subgrade group, so above or equal to 2, so a clinically significant prostate cancer. So our idea was to see if we can predict based on clinical and radiological parameters, if we can predict if those lesions are clinically significant prostate cancer or not, and to see who to biopsy and who to not to biopsy. So the aim of our study was to substratify patients from a large cohort of the European cohort, and those patients underwent MRI targeted and systematic biopsies for PI-RADS 3 lesions. So there were 4,800 patients recruited from 11 European tertiary care reference centers, and all the patients had MRI targeted and systematic biopsies. And those biopsies were eventually interpreted by dedicated uropathologists, and the MRIs were interpreted also by a dedicated genitourinary radiologist, and the biopsies were done by a dedicated urologist, so as a tertiary referral care center. And the patients' inclusion criteria were very simple. Every patient who had a PI-RADS 3 lesion on an MRI was recruited in our study, and the exclusion criteria were also simple, or there were also any missing information. Primary outcome of our study was the identification of covariates that were significantly associated with the risk of a clinically significant prostate cancer that we defined as an I subgrade group above or equal to 2 on MRI targeted and systematic biopsies.
Okay, thank you very much. And so what are exactly the predictors that you found for the people that haven't still read your paper? I don't know why, because everyone should read Prostate Cancer Prostate Disease Journal every day, but some may not.
So what we tried to develop 3 models. The first model of prediction was only clinical, where we had 3 variables, which is PSA density, age, and digital rectal exam, and only PSA density was a significant factor. When we added MRI parameters to this model, MRI parameters did not influence our model. We have exactly the same area under the curve. And when we added the previous biopsy status in the third model, this did not change also. So we kept only age and PSA density as primary covariates, and then we included these 2 covariates in a specific statistical model that's called a CHIDE analysis, which is a key to automatic interaction detection analysis. It's a statistical method that lets us to divide our population into subgroups based on variates that we give to our model. And then when we gave these 2 variates that are PSA density and age, only PSA density was the significant factor influencing our decision tree. And then this model, what's good in this model, that it will substratify our patient based on PSA density cutoffs. So when we told them our model, we want a two-nose model. So we want to divide our population into two subpopulations. It divided based on the PSA density inferior or superior to 0.13. And when we told our model now divide our population into three subgroups, there were PSA density less than 0.09, above 0.16, and between 0.09 and 0.16. And when we applied these criteria to our population, we see that when we have a PSA density less than 0.13, only 1.4% of patients will present a clinically significant prostate cancer. And it is only ISUP2 or ISUP3. And when you apply a cutoff of 0.09, it is way less, and it is only 0.6% of patients who have clinically significant prostate cancer. So this study is an update of the PSA density cutoffs that we see in the guidelines that were based only on systematic biopsies. Now we have an update with MRI targeted biopsies.
Well, I think this is an important game-changing data, because we know that PSA density in the latest years has been really useful to define not only diagnosis but also prognostical factors. So probably, do you think, because one of the main aspects of MRI, do you really think that these tumors that you find that are PI-RADS 3, I know that you don't have the answer, but what do you think? Do you really think that there are molecularly aggressive cancers? Because many people are saying that even if we find these cancers, these PI-RADS 3 are probably, from a genetical point of view, they're not that aggressive. So what do you think about this idea? Because I know I'm thinking about your personal opinion, because we still don't have the data. Probably future studies will give us the answer. But what do you think about this?
Maybe I can ask. I can respond. Yeah. So we have one very nice study from the UCL teams, and they analyze the genetic aggressivity in MRI visible and invisible lesion, and they found that when you have visible lesion, they are more aggressive compared to non-visible MRI lesion. So probably there is a correlation between the visibility and the aggressivity of tumor, but actually we don't have data regarding subtype of PI-RADS lesion. So we don't really know if PI-RADS 3 lesions are less aggressive compared to PI-RADS 4 or PI-RADS 5, but we know that MRI lesions, visible one, are more aggressive. The thing is, sometimes we don't really see the lesion, and there is some kind of inflammation or something like that at previous surgery in the prostate, and it's sometimes very difficult to find this lesion. And I think it's the reason why we don't really know if we have to do biopsy for this patient. And I think the main goal and the aim of the study was to stratify this patient, and I think there are more to do, and we have other biomarkers or maybe imaging that can improve our stratification. The main goal is to reduce patient burden and healthcare cost, because when you do biopsy, you expose your patient to risk, to cost. So we need more study like that. It's a first step, obviously, because we have a large database, and thanks to this database we can have good results and good first step for the future. But we need more prospective study and more study including this biomarker and imaging modalities.
And what do you think about the possible role of PET-PSMA in this setting? Do you think that it will have a role? Because nowadays it's just a staging procedure. Do you think that, we have this very interesting Australian study, which probably will give us the answer of how PSMA PET actually performs in this setting. But what's your opinion? Do you think that it's a little too much, or do you think that it's fair enough to get it to anticipate the use of PET-PSMA in this setting?
No, it's a very good question. So if we exclude the cost associated with PSMA PET, we already know with the primary trial from Professor Emmett that there is some kind of added value of PSMA PET for for patients with MRI lesion, especially for PI-RADS-free lesion. If you read the meta-analysis for Kawada in European Urology Oncology in 2022, they mixed data from 3 studies, and they found that probably there is a real interest for PI-RADS-free lesion. And I think it was the origin of the primary 2 trial, a randomized trial, also by Professor Emmett, where patients with PI-RADS-free lesion will be randomized for PSMA PET and template transperineal biopsy. Here at Jules Bordet Institute, we have an academic trial, the Pandora trial, and we also do a study on the PI-RADS-free lesion, and we use PSMA PET MRI. This is quite different because the primary 2 use PSMA PET CT. And thanks to the PET MRI, we can do fusion biopsy, and we can do precisely target the MRI and the PET lesion using the MRI modality. So quite similar outcomes, but different type of imaging.
Well, this is an interesting study, probably. As you said, I think the principal problem for the moment is cost from one side, but also burden of nuclear medicine. Because when you talk to these guys, they say that they are they have a little bit too much work, so they don't know how to manage all these patients, because it takes obviously much more time than other types of exams, and probably MRIs are all over the place, while probably PET scans are not that easy to build in a normal radiological center. And so what is your experience with the quality of MRI? Meaning, what do you do in your center? You have to review all the MRIs that come from outside. Do you have a good quality overall? What's your experience in the everyday clinical practice in Belgium?
So as George said, just for our study with PI-RADS-free lesion, so we use only data from academic and referral centers. So they are associated with dedicated radiologists, and it's very important. And there are some criteria for expertise, and we know that MRI quality, the image quality, are very important. And you have the PI-RADS score described, and now with the version 2 recently published. And I think it's a really important step to analyze and to have an objective score on the image quality, and obviously the radiologist expertise. And some criteria, for example, from the ESUR SUI was at least 1,000 MRI scans read and more than 250 MRI scan read per year. So there are some strict criteria to describe and to define radiologist expertise. And it's very important because when you see the anti-reader experience of PI-RADS score, anti-reader agreement, there's some variation, and I'm probably sure this variation is linked to the expertise. So for PI-RADS-free, it's very important because it's not so positive, so negative, and if you have less expertise, less experience, you don't really know. So you just say it's PI-RADS-free. I don't really know what it is.
No, it comes to my mind that do you think that with these recent publications on AI, this will be solved? Meaning that probably AI will give the PI-RADS score, and just the radiologist will have just to validate the PI-RADS score. Do you think that may give us actually the solution to all these variability in MRI reading and MRI reporting?
We have a recent study, an European one, published that compares the performance of AI-based predictive model for MRI analysis compared to radiologists, and the result was very impressive. And it's an open source AI model. Yes, I think it will be the future. We will have AI model that will give us the results, and radiologists will be there only for suspicious or equivocal lesion. It will be good help for us, but the principal problem is to generate this model to to have a good baseline and to have a good, amounts of MRI scan before to construct accurate models. So this is the main problem. But for the European study, was very impressive, and the results are very, very good for us.
Yeah. If I would be a radiologist, I would be worried about my future job after those results. So, Georges, tell me, I have a question for you. How do you do biopsies in your center? Do you do it cognitive fusion software? Do you do it transrectally, transperineal?
In our center, it is a transperineal approach, and it is a fusion biopsy coelis. Now it is recent, the transperineal approach. Within our cohort of patients, it was transrectal, but it is a retrospective cohort, and these are patients that were biopsied before. But now, since recently, we do all our biopsies transperineally and with a coelis fusion, 3D fusion with MRI.
And sorry for the question, but with the coelis, do you use a precision point or you use it freehand? Do you use the grid?
Yeah, the official grid. Produced by coelis, and very effective, very easy to do.
I think that's Romain, I think that's the only way to do it, because I don't know if you're in your experience, the learning curve without the grid, it's a little complicated. Freehand,
exactly,
it's difficult to learn, so patients don't tolerate it very good. So if you're not an expert guy on biopsies, it's really painful for patients. But we do it still transrectally because we don't have the software. But I used the coelis one, and I think that's probably one of the good. I mean, all the other softwares are good as well, but I think that every fusion software should have a precision point to help and guide the needle, and to avoid a little bit those problems of pain related actually to. So you're a transperineal team, I think. So
yes, and I agree with you. And the most important is to have a very easy, a good device, and with this grid it's very easy to do. And I think it's easier to do transperineal compared to transrectal biopsy. The most important is the anesthesiology. Is the first step of the biopsy is the most important one, because if you don't inject precisely, the locaine, it will be very painful for your patient. But for the biopsy itself, it's very easy. You don't have to scan the prostate. You have your 3D map. You just have to choose a letter and put your needle on the right hole, and that's all.
I completely agree with you. I agree that it's not anymore a painful procedure to learn. I learned the freehand, the transperineal, and I really believe it's one of the most difficult procedures to learn during residency. So we're getting at the end of our conversations. I'm very happy about what we went through. So how do you see the future of this sector, of this PI-RADS-free theme? So what do you think that the gaps are actually in the literature, and what do you think that people should focus on in the next few years to solve these important gaps in the literature?
Maybe George?
Yes, so I think mainly that the gap now is
how do you want to say? I think the gap today is the absence of big model that include different kind of data. For the moment, we only have the PSA density. It's a very easy one to have. One problem with the PSA density is how you define the prostate volume. It's first step, and then is how to manage all these data, imaging, biomarker, PSA, age, everything like that. So AI will be, I think, the future for that. The combination of all the data all together for giving us one answer. Do we have to do the biopsy or not? I think imaging will be also a big step in the future. Molecular imaging, and probably the fusion of all these things will help us to stratify patients. So we'll see in the next years, but
Can
actually there's a lot of study on that.
Yes, can I ask you an interesting question, because I think that this is something that is a little absent in the literature. So how do you define in yours, we have all these calculators, these nomograms, everything to actually establish a little bit the risk of prostate cancer. But how do you manage these risks? Meaning that you will never get a zero risk. So what, in your opinion, because, for example, for the Briganti score, we had a 7% risk, which was acceptable. But if you really think about it, we don't have an acceptable risk of prostate cancer. I mean, how do you define it? I mean, there are some interesting studies about mobile phone apps, about all these calculators, but actually they decide just which is the percentage of affordable risk. So how do you manage this with the patients? Because you can say, okay, Mr. X has a 3% of risk of clinically significant prostate cancer, but maybe for Mr. X it's not an affordable risk. What do you think about it? Because this is it's not when you read the papers, it's nowhere, meaning, okay, yeah, there is a lower risk, okay, we get it, but what is an affordable risk for the patient? That's my question. What do you think about it?
No, Ricardo, it's a very good question, and for the Briganti nomogram, this is a perfect example. If you read at the guidelines, before it was 5, 7, 12, 15%, and for different type of guidelines. So if you choose a country, you have different cutoffs. So how define that? It's very interesting because we just write a paper on that, an editorial with George regarding the cutoff in medicine, and the idea that we use cutoff because it's easier for us to choose a treatment, a diagnostic things based on a simple cutoff. But in reality, it's not a cutoff; it's a probability. Range from 0 to 100%, and we have to choose. So maybe George, you want to comment that, but we just write something on that, and we will send it to a journal in a couple of days. But maybe George, you want to comment?
Yes, in fact, we always love to sub-categorize patients, and it's very easy for us because when we categorize our patients and we see this patient is low risk, yeah, perfect, we don't do anything, but is it still a risk? Maybe if it's a low risk, there is still a risk, and this is why for us it's easy to have a nomogram that will guide us, because clinically, yes, this one I will biopsy, this one I will not biopsy, this one I will do an extended pelvic lymph node, this one I will not do a pelvic lymph node dissection. And it's very easy to us because it is simple in our clinical practice, and we need this. And this is perfect because before this, we didn't have any answer. Now, maybe we can say to our patients, okay, now you have 7% maybe risk of having this. And it is the importance also of discussing with the patients and saying to them that this is for now what we have. This is for now what we know, but we can do better. And I think that the future now is not continuing to categorize our patients, but what is AI is capable of doing is that interpreting continuous variable as continuous and not categorizing these variables. And this is where, for example, when we see the new study by Daniel Spratt about Arthur AI and interpreting pathological results of prostate biopsies, in fact, they do not pass by lesion scores or ISUP scores. They just say, this patient would benefit from hormone therapy, this patient would not benefit from hormone therapy, but not based on a risk or based on a subcategory of patients or based on a score or going from 1 to 5. Maybe it's 1.2, 1.3, and it's not just 1 or 2. So this is the future. I think that urology in the 10 years now, so after 10 years, maybe everything will change, I think.
But Romain, a question for you. But what is your acceptable risk as a patient? I know that you don't have still the years to have prostate cancer. So what would you say it's an acceptable risk for you? So it's a personal question. And what do you think? And what is an acceptable risk for your patient? Because when you try, because I've tried a little bit to do such a study, the end of the consultation is, okay, I'll do what you tell me to do. So you have to decide for the patient because he's not able to decide. I think he doesn't have the right tools to express what an acceptable risk is. So what is a percentage of acceptable risk for you, Romain?
As you know, Ricardo, there's no answer to that. We are lucky with prostate cancer because, you know, the evolution of this cancer is quite low. We have now good data for active surveillance, and I think if we just, you know, have some kind of delay, and we just say to the patient, we can wait, we can do more imaging, we can wait a couple of months of years. I don't think we just reduce the chance of treatment and it won't change the outcome at the end. So we need to be more focused on the risk of over-treatment, over-diagnostic. And it's a good question regarding the exact and what is a good or bad cutoff. We don't have the answer, and it will be, I think,
my question is for you.
Long-term question.
No, my question is
yeah.
for you. For you. What's your acceptable risk? You know, it's one. How do you gamble? Meaning, you accept a 5 or 10. So if you would were at risk, what's your acceptable risk?
Good question.
I mean, in my opinion, it's 5%. It's okay. I don't go over. So if my doctor says you have 7%, I'll go for biopsy.
Which question? For biopsy or not biopsy?
For biopsy or not biopsy? That's the question. So you get to I get to the doctor and he tells me, okay, you have a 5% risk. For me, 5% is acceptable. Even meaning that I can play with that, and meaning that I know that I'm talking about prostate cancer, so I have time, even if it's not the right, even if I have it, as you said. So the big difference with other cancers, I think, this is something difficult to transmit to patients, to understand that we're not talking about pancreatic cancer, which will kill you in a couple of months. So I think we have time. So I think that maybe, but that was my when I asked myself, my cutoff was 5%. 8%,
5 to 10, yeah.
5 to 10, because more yes. I wouldn't gamble. I mean, it's sometimes it's like gambling with your. No, it's gambling with your life. Actually, when you ask these questions to patients, you're telling them to gamble. So what's the? If you ever think of it,
5%. 5% is the worldwide accepted risk for everything. In fact, for all statistical tests, is 5%. For
George.
Yeah, maybe
5%
is logical.
George, I risk my life much more every time I get my car in the morning.
Of course.
I think that my risk of dying is much more on my car. That's how it goes.
Yeah, exactly.
So I think that we went through a very, very important aspects of this topic. So I will give you the last words to conclude on what you think it's important for the audience to remember on your article, and then I will close the podcast. I think that we really did a very nice conversation. So please, George, conclude. It's your honor to conclude.
So as a conclusion, when we have a PI-RADS 3 lesion on an MRI, always do calculate PSA density. And if you have a PSA density less than 0.13, and especially less than 0.09, you could omit biopsies and you could just follow up your patients.
Okay, everyone who's tuned and is listening to this podcast now, there you have a clear message, so you can change a little bit your clinical practice. I think that data is solid, and I think that we are really slowly changing the game in prostate cancer diagnosis. So thank you, everyone. This was another episode, fantastic episode of Prostate Cancer Prostate podcast. Thank you.